So, good evening, everyone. We are at our monthly PG case presentation, Spice Road Tamil Nadu chapter. Today we have Dr. Nimmi V H. She is my dear junior from UG. She is doing her family medicine DNB from SKS PG Institute, Hospital and Postgraduate Institute from Salem. So today's moderator is, we have two moderators today. So first I would like to introduce Dr. Ruby Angel and Priscilla ma'am. She's our Ojetion of the Family Medicine Department of CMC Vellore. So ma'am has been there in LCSU for more than 20 years, practicing primary care OG and also practicing family medicine along with us. So I welcome you, ma'am, to moderate the session. And I have my dear senior assistant professor, Dr. Don Thomas. He is an assistant professor who has finished his PG from CMC and has working as an AP at CMC Vellore in LCSU. So today we are going to have a PG presentation. So I think let's go with the clinical case scenario and we'll continue from that. Okay, ma'am. Shall we start, ma'am?
Yeah.
Please start.
Can I start?
And before starting, I just want to have one more thing. It will be nice if every one of you can switch on your video and switch off your audio. And if you really have something to add on or ask about, you can obviously ask in the comment section, and you can also ask as an audio whenever we have the chance, we have the time, we have the gap. So it will be nice if all the PGs switch on their video. So we'll be able to see your faces and we'll be able to interact. So it's also to you, Nimmi. So if it's possible, so we'll also know who are who, and otherwise it's also feels like you're talking to a computer. So whoever is possible, please switch on your video if possible. And I think it's also like a get together, get to know each other and about your practices, your current curriculum, and your work in your institute. So yes, I think we can start, Nimmi.
Okay. Good evening, respected sir, ma'am, and dear colleagues. Today, myself, Dr. Nimmi. I'm second year DNB Family Medicine resident, and here I'm to present a case for the today's discussion. My patient, she is Mrs. Rani, 68-year-old, homemaker. She is from Hasambati, Salem, and her date of admission was on April 1st, 2026, and I have evaluated her on 2nd April, and she belongs to an upper middle class according to the modified Kupusamy scale. She came with chief complaints of spotting for vaginum for 2 years. History of presenting illness. She was apparently normal 2 years back, after which she has developed spotting for vagina, which was for 2 years, which is on and off. And she developed the symptoms 7 years after her menopause. And the minimum duration of the symptom was for 1 day and the maximum duration of 4 days. And currently, she came for the same complaint, spotting for vagina, for 5 days, which is not associated with passage of clots or pain. There is no history of pain abdomen, mass abdomen, trauma to the abdomen, mass descending per vagina, no history of bile discharge per vagina, no history of postcoital bleeding, no history of loss of weight or loss of appetite, no history of constipation or straining while passing stools, no history of urinary frequency, urgency, dribbling, incontinence or straining while passing urine, no history of usage of contraceptive pills, menopausal hormonal therapy or anti-cancerous medication in the past. Moving on to the past menstrual history, she attained menarche at the age of 13 years. Her premenopausal cycles were regular, which was occurring every 27 days, and bleeding lasted for 4 to 5 days, and she used 2 to 3 clots per day, and there is no history of dysmenorrhea or passage of clots. Moving on to the menopausal history, she attained menarche at the age of 59 years. And there's a history of sudden sensation of heat around the face and chest, lasting 5 to 10 minutes, on and off for 2 years, which is not affecting her daily life. There is no history of menopausal hormonal therapy. Obstetric history. She was married for 55 years. At the age of 14 years, she got married, and her husband expired 5 years back. Her obstetric score is P4L3, and which was all normal delivery. Except for the last child, all were alive and healthy. The last child died because of the coronary heart disease. The age of first child is at 15 years of age, and age of last child is 47 years. She is not sterilized. Moving on to the past history, medical history, she is a known case of diabetes for 5 years, hypertension for 5 years, and dyslipidemia for 5 years, and hypothyroid for 25 years on treatment. No history of screening for cervical or breast cancer done. And surgical history, she underwent laparoscopic cholecystectomy 10 years ago. Family history, there is no history of endometrial cancer, breast cancer, ovarian, or colon cancers among family members. Personal history, she consumes a mixed diet and her appetite is good and she sleeps for 7 hours continuously. Her bowel and bladder functions are normal. No smoking, alcohol, or tobacco use in the past. Treatment history, she is currently on medications for diabetes, hypertension, dyslipidemia, and the hypothyroidism, along with for the peripheral neuropathy. She is on regular treatment and her comorbidities are well controlled. Moving on to the individual assessment using the RISES framework. Actually, the reason for visit is the patient now presenting due to the recent episode of sport. Previous episode, her ideas are she perceives this bleeding as age related initially and did not consider it serious earlier. And now the concerns are fear of malignancy, anxiety regarding the investigations like biopsy and the further investigations, concern about comorbidities affecting treatment. And the expectations what she has is relief from bleeding, preference for medical management if possible, and wants a clear explanation and guidance. And there's no significant limitation in daily activities. And she is mild. She has anxiety related with the current illness. Contextual factors: she is a widow, lives with her children with good family support, and she lives in a stable home environment. There's no issues of violence or poverty. She has basic schooling, and she's a homemaker, and religion is not contributory here. And she's a right-handed person, belongs to an upper middle class, financially stable, and she has an anxiety related to the current illness. Moving on to the summary, Mrs. Rani, a 68-year-old postmenopausal woman, attained menopause 9 years back, and P4L3, previously normal menstrual cycle, presented with intermittent spotting for vagina for past 2 years. From this point, the possible differential diagnosis could be the endometrial, it could be endometrial atrophy, hyperplasia, carcinoma polyp, and in cervical, it could be carcinoma cervix, cervical polyp, and vagina, it could be atopic vaginitis, and ovarian, it could be estrogen secretory tumors. So it can be either benign cause or malignant cause. So ma'am, can I proceed with the examination?
I have one question for you. What is another important risk factor from your history? I'm seeing one drug there.
From the drug aspect, ma'am? Ma'am, actually, she's a known diabetic, ma'am. That is a risk factor. Then this clopidogrel she consumes, there is a tendency for bleeding manifestation.
That's one of the risk factors, no? You have to highlight that actually. And how many years she's on clopidogrel?
Clopidogrel for the past 5 years.
Okay, okay, ma'am. So that is an important risk factor, huh? Clopidogrel.
Yes, ma'am.
And also hypothyroidism.
Yes.
So, can you tell a little about the family history of this patient? Did you assess the family?
So actually, the family they belongs to a upper middle class, and I have asked whether the other family members are suffering from the same kind of illness, whether her mother or whether her daughters, whether they are suffering related to this illness. But she said
Okay.
no.
So yeah. So what makes family medicine case a little different is the family assessment, and there is something called as family ABCAR. Okay, so that is to find out what is the functionality of the family. So in a case of postmenopausal bleeding, woman with postmenopausal bleeding, and we want to also see whether how is the family, whether how is the family supportive to the patient's needs and patient's issues also. So you need to know how functional the family is. So to assess the functionality of family, there is a scoring system called as family ABCAR.
Okay, sir.
APGAR, APGAR. Okay,
Yes, sir.
so there are so many family assessment tools, and one simple tool that can be used in a case presentation easily will be a family APGAR. There are
Okay.
some other tools also, tools called as Scream, tools called as Family Echo Map is there, but something easier that can be used in the case presentation will be family APGAR. And when it's a family medicine case presentation, I think family APGAR will be very important because that is also needed because um, that the family, the context, the individual aspects all affects the patient's treatment and also the later on diagnosis also. Okay.
Shall I just add one more thing to the family APGAR? I will be sharing about what family APGAR is in the groups once the meeting is over. But as Don sir rightly said, it includes 5 components. Just want to just highlight upon what is family APGAR. Basically, uh, family APGAR means adaptation, partnership, growth, affection, and resolve. So basically, uh, you know that the family is able to adapt to any difficult situation and will be able to support you. Partnership means whether they'll be able to as a partner with me in leading my life on an everyday basis. And also growth basically means like they'll be helping me in my personal or professional growth, and also helps me in supports me in pursuing my wishes in my life. And affection is I am happy with the way that that I am being loved in my family and supported in my family. And I know that I am satisfied with the relationship with my spouse and children and my parents in my family. So I will share the details shortly. So it's a very simple questionnaire which you can actually use, which can mean more about, which actually means more in our practice, because any dysfunctional family which you note, then managing them is going to be more difficult because of the poor family support. We may just say that the poor family support, but uh, this will actually help us in guiding what kind of the intervention the family needs, so as to for the patient, for us to help the patient. So I think, am I right,
Yes,
answer?
yes, yes. It will help us in tailoring the treatment for that patient. It will be more patient-centered. Treatment or the management plan will become more patient-centered.
And
Can just go to the individual history, Dr. Nimmi.
Yes, sir.
Individual history.
individual history, individual factors, da.
Yes, sir.
Uh,
Can just show
1 minute.
individual.
you put rices, no, da.
Yes,
Rice.
sir. Yes, ma'am.
So S you have written as
Effective function or life, sir.
okay. I think that is spirituality. Can you just make sure S is for spirituality? So
Okay, sir.
basic, yeah. So yeah, one tool we use is Hope questionnaire or the FICA questionnaire to assess the spirituality. Also, there is spiritual distress and spirituality also need to be assessed. Okay, during exam, I don't know how much we can assess it, but as a family physician, spirituality need to be assessed in all the patient. And again, coming to the individual factors, no, the contextual factors. The next slide. Yeah, you have written about the parameters in the context. But when it comes to contextual history, we have to say how these parameters are influencing the patient, or how the patient is influencing these parameters, like whether she is a sole breadwinner of the family, or who is taking care of the family. All those things will come under the contextual factors. Okay, basically the structure, or what all is affecting her as an individual, who all is affecting, or what all is she's like, what all she is influencing and what all is influencing her. That is what comes under contextual factors, rather than points like this. Okay, these all are
Okay.
there, but how these things affect her and vice versa. That's what contextual history is. Okay, yeah,
Okay.
you can go ahead.
Moving on to the examination part, general examination. She is moderately built and nourished. She is conscious, cooperative, oriented to time, place, and person. There's no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pituitary edema. Her spine, thyroid, and breast examination are normal. Vital signs: pulse rate 88 beats per minute, which is regular in volume, regular in rhythm, normal volume and character. And BP 130/80 mmHg measured in the right arm in sitting position. Respiratory rate 18 breaths per minute, and she's afebrile. And her height is 152 and present weight is 100 kgs, which is BMI of 43.3, which belongs to class 3 of WHO classification. Systemic examination, CVS, S1, S2 heard, and there's no murmur. A respiratory system examination, bilateral normal vesicular breath sound heard, no added sounds heard. CNS examination, there is no focal neurological deficit present. Moving on to the per abdomen examination. Inspection, abdomen appears to have a normal contour. All quadrants move equally with respiration. Umbilicus is central in position, inverted. There is no sinuses, dilated vessels or scars, no visible pulsations or peristalsis. All hernial orifices are free. Palpation, there is no localized warmth, soft, no non-tender, no organomegaly. Tone of abdominal wall muscles are normal. Percussion, diffuse dullness is present due to obesity. There is no shifting dullness, and normal bowel sounds are heard on auscultation. Local examination, inspection of external genitalia, pubic hair is sparse, labia majora and labia minora is atrophied, external urethral meatus is normal. Perspicular examination, there is no ulceration or mass seen. Vagina is dry and less mucous, and there is bleeding through the cervical os present. Per vaginal examination, uterus is anteverted, atrophic, mobile, and the fornices are free. Per rectal examination, rectal mucosa is free, sphincter tone is normal, perineum normal, and parametrium and pouch of Douglas are normal. Moving on to the summary, 68-year-old postmenopausal woman. She attained menopause at the age of 59. She is multiparous, P4L3, known case of diabetes mellitus, hypertension, dyslipidemia, hypothyroidism on treatment. She presents with on and off postmenopausal bleeding per vagina for 2 years, which is associated with hot flushes. And on examination, she belongs to obesity class 3 and a bleeding per vagina present. So provisional diagnosis could be it's a case of postmenopausal bleeding. So it can be either benign pathology or malignant pathology. So the main differential diagnosis could be atrophic endometritis, atrophic vaginitis, endometrial hyperplasia or carcinoma, and ovarian carcinoma. Here the risk factors mainly present are obesity, it's an unopposed estrogen, diabetes, hypertension, dyslipidemia, it's all metabolic risk, and late menopause. These are all points towards the endometrial pathology, most probably endometrial hyperplasia or carcinoma. That's all, sir.
So how it also add risk factors of hypothyroidism, clopidogrel intake. Okay, keep that as one of the differentials.
Yes.
So how will you manage this patient?
Management first, investigations, ma'am. The routine investigations like CBC to look for the anemia status, CBC, then coagulation factors. Then we'll proceed with the ultrasound, ma'am. And all the cases, like in case of a postmenopausal bleeding, unless we have to rule out the malignancy, so we have to, if the endometrial thickness in USG TVS is high, like more than 4 mm, we have to proceed with the endometrial biopsy also.
So in this patient, you have to do thyroid.
Yes, ma'am. Sorry, thyroid.
And also diabetes status you have to monitor.
Diabetic. Diabetic
Those
and
yeah, dyslipidemia, all that you need to check. And then, of course, the imaging is very important as well as biopsy. So, anything else? Why are we doing the imaging?
imaging to look for the endometrial thickness and the status of uterus, ovary.
Ovarian tumors also we have to rule out. So,
Yes,
two
ma'am.
things you have to
Estrogen secret.
keep in mind, either endometrial pathology or ovarian pathology. Both can cause postmenopausal bleeding. And also we need to do cervical cytology also.
Absolutely.
And so how will you proceed with this patient?
Based on the investigation. Like for this patient, we have did the TLH plus BSO, ma'am, along with the sentinel node biopsy, ma'am. And the sentinel node biopsy came out to be negative, and she was staged under stage 1B, ma'am. And now she is waiting the reports of molecular profiling, ma'am.
Sorry,
Hello, ma'am.
I didn't get the last part. What did you all do?
The molecular.
No. What did you all do? You did biopsy?
Biopsy, ma'am. Then we have proceeded with TLH plus BSO with sentinel lymph node biopsy, ma'am. And which came out
surgery is
negative.
over.
Yes, ma'am. It's over.
Okay, what was the endometrial biopsy?
1 minute, ma'am. Check. Sorry. The biopsy report has come as grade 2 endometrial CMM, less than 50% of myometrium with no nodes involved, ma'am. She is staged under stage 1B.
No, that is your hysterectomy specimen.
Yes,
I'm
ma'am.
asking the endometrial specimen. Endometrial, you must have done endometrial biopsy, right?
Yes, ma'am. Yes, ma'am.
What did that come as?
Hyperplasia with atypia with features suggestive of adenocarcinoma, endometrioid type endometrium.
Oh, okay. So it did come back as malignancy. Okay. So they did total hysterectomy with bilateral salpingo and node biopsy.
Sentinel lymph node biopsy.
Okay.
Now she's waiting for the molecular profile.
Okay. Don, anything else you want to add?
If the biopsy had come back negative, endometrial biopsy had come back negative, what would I have done?
We'll keep under her on follow-ups there, and also we have to like roll out this benign causes also, like atopic vaginitis. Then we have to
one thing, how do you keep her under follow-up? And she has her distressing symptom now is the spotting. If it was not endometrial carcinoma causing all these things or any other cancer that is not causing this bleeding, how do you manage this symptom of hers?
We'll put
How
her
do you
on.
keep?
One thing is the management of risk factors along with the controlling of bleeding by giving TRAP itself, tranexamic acid tablet.
Okay. Yeah.
Then controlling of diabetes, hypertension, and dyslipidemia. And
Okay.
also she has to, like, she's obese also, like we have to advise her lifestyle. Then along with the local estrogen, like the atopic vaginitis part.
Yeah. If there was atrophic vaginitis or atrophic atrophic vaginitis, what will your treatment be?
Local estrogen supplements like estradiol
Okay.
cream.
Okay. Yeah. Then if yeah, this is okay. How will you keep the patient at a follow-up? What was her TVS finding? Do you remember endometrial thickness?
ET. What was the ET?
One minute. I don't have that USG finding also.
Okay. So postmenopausal bleeding. So even if the ET was less than 4 millimeter, also we would have done an endometrial biopsy anyway in this patient because of all the risk factors that is there. We would have already anyway done the endometrial biopsy for this patient to rule out a ATP or a malignancy there. So one to keep her under follow up will be routine ultrasound, maybe every 6 monthly or 1 yearly, to check for the ET. Or maybe if the patient is having a increased bleeding thereafter, we will repeat an endometrial biopsy after 6 months to 1 year also. Okay.
Yes, sir. She was asked for the follow-up, like for till 2 years, so 3 monthly follow-up, followed by for next 3 years, 6 monthly, and afterwards like annually follow-ups.
Yeah. In this case, right?
Yes, sir.
Yeah.
Was she asked to follow up like that?
No, that's
Yes.
because it's malignancy.
It's already malignancy. It's already malignancy, right?
So, but if it is not malignancy, what would your management changed in any way?
Like maybe once in 6 months.
Actually, she has so much of risk factors.
Yes.
I would have anyway advised her TAH-BSO. Somebody who's spotting for 2 years. So we have to individualize the treatment for patients, even though we can say postmenopausal bleeding, no evidence of malignancy. You have to see the risk factors also. This patient has so much of risk factors actually.
Yes,
So it's even if the biopsy had come back as normal, it's still, I think we should advise TH-BSO. But in this case, of course, there is no doubt that she needs to have only the surgery. So after immunochemistry, will they be giving some chemotherapy or brachytherapy or something? We don't know.
No, ma'am. Actually, the molecular profiling, it takes for at least 2 weeks, ma'am, for the report to come. So we are waiting for that.
Okay. Actually, you presented quite well, very comprehensively, especially the history. And I think in the pelvic exam, you may need to add some more points, I think, like color of the cervix, color of the vagina, and things like that. Any discharge and But otherwise, I think it was quite a good presentation.
Okay.
And don't stop with diagnosis. You go ahead and tell how you're going to manage this patient.
Okay.
You don't need to wait for the examiner to ask you questions. You need to tell your differentials and you start telling how you're going to manage the patient. Exam, I think you should not give the examiner a chance to ask you any questions. Okay.
Suppose, ma'am, suppose it is just atrophic vaginitis, then what is the treatment for the spotting? Can we put her on in this case because she is obese and there's also a family history of coronary artery disease? Can we put her on combined oral contraceptive pills or oral estrogen and LNG IUS?
For her, hormonal
For the
treatment is
spotting,
out
what
of
do we
question.
do for the spotting?
That's what I'm saying. No, even if the biopsy had come back normal, I would have advised hysterectomy for this patient because so much of risk factors she has. And postmenopausal bleeding is something which we cannot take it lightly, actually. Okay, so that is one thing. And hormonal treatment at that age group, especially combined OCPs and all, are totally out of question. And if you want to give progesterones also, you have to give continuously. But for this patient, I won't use hormones.
LNG IUS?
No, not in this age group.
Okay.
Perimenopausal, okay.
Okay.
Not in postmenopausal age group. We don't put in Mirena and all, so to speak. Yeah.
Yes, ma'am. Okay, thank you. Thank you, ma'am.
If she didn't have any comorbidities, maybe we should keep her on follow-up. Even then, I tell my patient, anybody with recurrent postmenopausal bleeding, better to operate. Because sometimes your endometrial biopsy can miss some side of the uterus and you may miss some hyperplasias, atypias, and then they may later come with advanced cancers.
Okay.
So it's better to advise the patient postmenopausal bleeding, even if the biopsy is normal. I mean, you keep under close follow-up, but still you have to give them that information that if it is recurrent, better to have the surgery.
Thank you, ma'am.
Yeah, no problem.
Thanks, Dr. Revati, for a very wise question. Does anyone have any other questions right now? If you have any other questions, you can also come up in the chat box. Dr. Jaya had mentioned that more than 4 millimeters for postmenopausal. Yes, more than 4 millimeters for postmenopausal is more suggestive of an hyperplasia or ATP or malignancy. But as ma'am and sir already said, any postmenopausal bleeding needs biopsy along with the ultrasound and other evaluation. So Nimmi has done a very good job of presenting postmenopausal bleeding. I do have something to share about the same. Shall we have a small presentation on AUB management and primary care? If shall I start, ma'am?
Yeah, sure.
One second. As we have the opportunity, I thought we'll also discuss about common scenarios that we have with abnormal uterine bleeding in primary care. So, I hope my screen is visible, right?
Yes,
and my audio is audible.
Yes.
Okay. Yeah. The current guidelines for abnormal uterine bleeding has changed than before. So as we have seen in the screen, the normal frequency of menses should be between 24 to 38 days. It was before 21 to 35 days. Now it has become 24 to 38 days. Similarly, the regularity of cycle, that is the cycle to cycle variation should be around 2 to 20 days in between. That is, say, one cycle can be 7 days later than the other cycle. The intracycle regularity. And the duration of flow is also is 4.5 to 8 days. Similarly, the normal monthly volume of blood loss should be 20 to 80 ml. So if there is any deviation from the normal frequency, duration, regularity, or quantity, we classify them as abnormal uterine bleeding. So AUB can be classified as acute or chronic AUB. So I would like the audience to also have an interactive session. You can please switch on the video and sorry, my presentation is gone. So I would like the audience to be also engaged in this. So I want someone to switch on their audio and answer. So what would you do when a patient comes with an acute increased menstrual bleeding PV with tachycardia and hypertension, BP of 90/60, also complaining of giddiness? So say she is a 25-year-old woman who is married with an increased menstrual bleeding PV for the past 2 days, and she is tachycardic and hypotensive, BP of 90/60.
Admit her and rule out ectopic pregnancy.
Yes, that's the first step that we do. Yes. Pregnancy-related bleeding PV is something to deal with another day, but yeah, that has to be done immediately, and it's they have to be immediately referred to a higher center for further surgical management. Say if the urine pregnancy is negative, then
we'll secure IV line and take sample for blood grouping and cross matching.
Yes, very good, Dr. Susan. Yes.
And then start on IV fluid.
IV fluid.
And also for HB and.
Okay. How much can you give IV fluids in a patient with this hypotension, anemia? What will you look for while you're giving IV fluids?
Whether she has any features of cardiac failure.
Okay, very good.
Only condition IVC status.
Sorry?
Check for
IVC status, ma'am. Like
whether?
Am I audible?
Yeah, now you're audible.
Yes, ma'am. Like to check the IVC status, ma'am, before giving fluids.
You can check IVC status in giving fluids, but most of the primary care may not have an ultrasound machine with you. You may not have an ultrasound machine always in your clinic.
Check for Krebs, ma'am.
Yes, we can check for Krebs. Yes, obviously. While giving fluids, you can monitor properly, connect a monitor, connect a BP machine, keep on continuous monitoring, check for BP, check for Krebs, check for any worsening of breathlessness and all. Yes. IVC is a more accurate measure of measuring fluid responsiveness, but it may not be available everywhere. So, okay, you have given fluids, her BP has picked up, but she's still bleeding.
Tranexamic acid injection.
Tranexamic acid.
Can someone tell the exact dose? How do you give?
500 mg, ma'am. We can use up till 1.5 grams.
How do you give tranexamic acid? Sorry. How do you give tranexamic acid?
We can either give in 10 ml NS, 1 gram tranexamic acid, or 5 to 100 ml NS. Okay,
very good. Okay. We've given tranexamic acid. So it's 25-year-old woman. Dr. Jaya, I think, can you mute yourself? Or Nimmi, can you mute Dr. Jaya? Yes, thank you. Yeah. Yeah, you've given tranexamic acid. What else you can give before the blood comes in and before the reports comes in? And what is the what do you think will be the common causes in this age group, and what do you think will actually benefit her and reduce her bleeding? Tranexamic acid, yes, of course, it will reduce bleeding. What else will reduce her bleeding? Anyone wants to add on, or shall I continue?
Vitamin K.
Vitamin K has not been proven much helpful. It's helpful only when there is a vitamin deficiency, as in neonates and patients on warfarin. Even patients with clopidogrel, vitamin K may not help. But if anyone has no ideas, I think I'll continue with the presentation. We'll discuss about it much later.
If available, we can give IV estrogen.
Yes, IV estrogen can be given, but it's not commonly used nowadays. Instead of IV estrogen, what else can you give if there is no IV estrogen?
Can we use misoprostol in non-pregnant?
Ma'am and answer, you can also answer. I think misoprostol may not be advisable in non-pregnant women because it is going to even increase the prostaglandin secretion and increase the bleeding.
Okay, ma'am.
Misoprostol is mainly used to expel the contents of the uterus. They have already been expelling in case of non-pregnant adults more excessively.
Okay.
Basically, instead of IV estrogen, what we can give is a low dose combined oral contraceptive pills or even orthosterone. Ma'am, can we use Meprate in case of acute bleeding? Because does it have any estrogen action? I am also confused about that.
That is all progesterone, only progesterones. But with tranexamic acid, we can supplement with if the patient is stable and able to swallow, then you can give oral norethistron dose. But this sort of patient actually will need transfusion anyway, tranexamic acid. And of course, you have to rule out pregnancy and pregnancy-related complications first before we go ahead with anything else.
Yes, ma'am. So I think you've all engaged very well. So we'll continue with the presentation for now. And also AUB class B classified as a pre-pubertal, reproductive, perimenopausal, and postmenopausal. And also there is another classification of AUB as mild, moderate, and severe. So in case of mild AUB, the hemoglobin level will be usually between 10 to 12 gram percentage, in which reassurance and lifestyle modification can be sufficient in the initial stages. They may require withdrawal bleeding with progesterones or occipils if persistently irregular cycles. Whereas moderate AUB will have an hemoglobin of 8 to 10 gram percentage, in which iron replacement and with low dose occipils or progesterone pills preferred. Low dose occipils are usually preferred less than 40 years of age, mainly because of the estrogen component can actually can produce deep vein thrombosis, coronary artery disease, and worsen the other atherosclerotic diseases. So less than 40 years of age or even less than 35 years who is obese, overweight, it's better to go with the progesterone only pills. Sorry. In case of severe AUB, they may need admission and blood transfusion. So we all have heard about the PAM coin classification of AUB. So PAM stands for structural causes, P for polyp, A for adenomyosis, L for leiomyoma, and M for malignancy. Coin C stands for coagulopathy. As ma'am rightly said in this patient, clopidogrel can cause an AUBC, in fact, which we have to also think about as a differential diagnosis. O for ovulatory dysfunction, E for endometrial, I for iatrogenic, and N for not classified. So let's Nimmi, can you read the scenario to everyone?
Yeah. Scenario 1, a 16-year-old woman, irregular cycle. She came with complaints of.
It's going on. One second. Yeah.
She came with the complaints of irregular cycles since menarche. Now with the history of increased bleeding PV after 5 months of amenorrhea. She has been tired, weak for the past week. She complains of mild shortness of breath on running. And her vitals pulse rate is 120 beats per minute. BP is 100/60. And she's paler, and her systemic examination is normal.
So anyone can answer. In primary care, this patient comes to you. So what do you do initially in primary care?
Any bleeding disorders have to be ruled out, like PT, APTT. bleeding time, clotting time can be.
Yes. Okay. Okay.
C-
Is this the most?
CBC should be done for basically to identify the level of anemia, and if needed, we should treat it first, followed by the further investigation we should proceed with. It would be mostly likely the hypothalamic, amateur hypothalamic ovarian axis, the reason. So based on that, we can treat it.
Yeah. Anyone else has anything to add upon? I think only 3 of them are answering in the.
And UPT should be also kept in mind.
Yes, 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 of course. Okay. So, as they've already rightly pointed out, we already discussed about this acute menstrual bleeding with the hypertension. As everyone has already said the same thing now. So, we do CBC, blood group, cross-matching thyroid. And what is the most, bleeding disorder is the most common cause of AUB in this age group? I'll repeat the question. Is AUBC, bleeding disorders, is the most common cause of AUB in this age group?
No,
ma'am.
it's not. The hypothalamic pituitary axis, that is the
Yes, as
reason.
Dr. Raj rightly pointed out,
Reason.
it is the hypothalamus pituitary axis is the more common cause, and bleeding disorders only point to 8 to 10%. So, does all patients with severe AUB needs the baseline screening for coagulation disorders has to be decided on a individual basis. Not everyone may not need is what I'm trying to point out here. So, indications for screening in AUBC in pubertal age group is heavy menstrual bleeding since menarche, any surgery-related bleeding or bleeding while dental work, brushing, and 2 of the following: bruising 1 to 2 times per month, epistaxis 1 to 2 times per month, frequent gum bleeding, or any family history of bleeding symptoms. Those need screening for coagulation disorders. Not everyone does need. So, if you find a person, a family who is already struggling, they may benefit more with the blood transfusion and hormonal therapy than the evaluation for screening for coagulation disorders. Ma'am, sir, do you want to add on anything for that?
No, what they said is correct. That hypothalamic pituitary axis is the commonest reason deficiency of that axis. But baseline things like PT, APTT, we have to do platelets, CBC, we have to do. No need to investigate for bleeding disorders if none of these things are there.
Okay, yes. So, case scenario 2, can Dr. Revati read this?
A 30-year-old woman presents with increased menstrual bleeding with intermenstrual bleeding during the last 3 cycles.
So, I didn't mention her vitals is stable. Her examination we are going to do. So, what do you think are the common causes in this age group for increased abnormal uterine bleeding?
30 years.
Industrial polyp.
First and foremost is always ruling out a pregnancy and pregnancy-related bleeding PV. Right? Even if they are sterilized. And yes, and then polyp. Anyone wants to add on anything to it?
Kind of IUDs that
Pap smear has to be done.
Okay.
For her.
Ovarian causes.
Ovarian causes, yes, can be present. Less likely to start at this age. Sorry, someone had said something.
Fibroid, ma'am.
Fibroid, yes. So, after ruling out pregnancy, I've made a synonym. It can be PAL. So, polyp, adenomyosis, and leiomyosis is the most common cause of AUB in this age group. As we already discussed, hemoglobin, thyroid can also be present. Ovarian cancers can also be present now. Hemoglobin to assess the severity of bleeding, and ultrasound is needed if you suspect any structural abnormality, any increase in uterine size, any adnexal mass you're saying. Another important cause is also pelvic inflammatory disease. Can present with an increased menstrual bleeding in this age group. Which can be detected clinically itself. In that case, treating the pelvic inflammatory disease can actually reduce the bleeding PV, reduce the AUB. So ultrasound is needed if there is any structural abnormality present, and if you feel that the uterus is normal size and it is a mild AUB, they may not even need an ultrasound in the initial stages when they present to us in the first or second episode in primary care. We can treat them with tranexamic acid and mefenamic acid, and we can follow them up on an OPD basis if you feel that they will be willing to follow up. And also, in any patient more than 40 years of age with an AUB, endometrial sampling is needed. And also, if they have other risk factors, less than 40 years with the diabetes, metabolic syndrome, they may need endometrial sampling because of the increase in metabolic syndrome and endometrial carcinomas in the current age. Ma'am, do you want to add anything, ma'am? Sir, ma'am.
Somebody mentioned PCOS also in the chat.
Yes, ma'am. I couldn't open the chat at all.
Yeah, it's a possibility actually. That is also, you should keep that also in mind. But only thing is PCOS, they won't come with the heavy menstrual bleeding. Maybe anovulatory cycles.
Usually presence with anovulatory bleeding.
Yeah, that's what.
One second. Yeah, scenario 3. So a 48-year-old woman known type 2 diabetes came with decrease in frequency of cycles with prolonged menstrual bleeding each time lasting for 7 to it is for 7 to 8 days. That is decrease in frequency of cycles with a prolonged menstrual bleeding during every cycle. That is 10 by 60 days cycle for the past 7 to 8 months. So her vitals are stable. BMI is 28 kg per meter square and examination is normal. So what is the next step? Can anyone add upon? So in case of perimenopausal AUB, ovarian endometrial malignancy are the common causes that we have to look upon. They may also have other causes like leiomyomas and endocervical polyps, but they're less unlikely. So obesity and metabolic conditions predisposed to malignancy, those has to be also taken into consideration in patients with perimenopausal AUB to assess the risk for malignancies. So as we have already discussed about, somebody has tested pap smear. Yeah, pap smear is required from age 30 or 3 years after the age of marriage. We have a screening protocol which separately can be discussed elsewhere. So these patients also need hemoglobin, thyroid, metabolic factors assessment with cytology, USG and endometrial sampling. So if all the common conditions are ruled out and it's only an ovarian cause of perimenopausal AUB, they can be given hormonotherapy with progesterone only pills. OC pills are not preferred in this age group, mainly because of the increased risk of cardiovascular events and thrombotic events. So also postmenopausal, anything to be added in the perimenopausal age group, ma'am? Non, sir.
No.
I think we discussed it more in detail. So postmenopausal bleeding, as we have already discussed today, as so the ET of 4 millimeters has a sensitivity of 95% for endometrial malignancy. So there is still 5% of people who may have an ET of less than 4 millimeters. and a specificity of 53% for endometrial malignancies, which means so they need an endometrial biopsy in case of postmenopausal bleeding. So since our case today is mostly on endometrial malignancy, we all know about the important risk factors for endometrial carcinoma: older age group, postmenopause, unopposed estrogen exposure. Important points being obesity, nulliparity, PCOS, estrogen secreting ovarian tumors, late age at first childbirth, and also patients on HRT. Some patients may be on HRT for various other reasons, for atrophic vaginitis or hot flushes, and tamoxifen use in case of breast malignancy. And hereditary causes also play an important role in case of endometrial carcinoma. Family history is more important in these patients, in patients with even postmenopausal bleeding, so that we'll be able to prevent an endometrial carcinoma in the current generation. So as we all discussed, endometrial biopsy is the next investigation once the initial evaluation is done. Pipal biopsy is more than sufficient, which can be done in primary care in all our clinics as an OPD-based procedure, which I think every PG should learn, a must skill that they have to learn. Pap smear and pipal biopsy, I think, is a must skill to learn in your institute. So if they are doing a pipal biopsy, make sure that you will go and learn it. It is not something very fancy. It can be easily done in your practice. So it has sensitivity of 99% and specificity of 98% in detecting endometrial malignancies. So what if the patient has only an what if the patient has only an endometrial hyperplasia? We have also discussed that briefly, but in case of give me 1 second. So in case of endometrial hyperplasia without atypia, I think anybody can see the PPT, or should I have to zoom the page? Sorry, 1 second. Everybody able to see the PPT?
Zoom
yes,
it's
ma'am.
better.
Huh?
The zoom that page.
Zoom.
I'm trying to do that. Give me 1
Yeah.
second. Yeah.
Yeah.
So endometrial hyperplasia without atypia, we have to look at the risk factors. As ma'am rightly said, if they have a risk factors and fertility is not required, surgery is not contraindicated, it is always better to go with hysterectomy, even without atypia. And if we are planning for an observation and follow-up, they need to be started on progesterone supplementation, which can be Mirena or an oral progesterone. Both can be used simultaneously. I mean, both can be used one or the other. And in case of endometrial hyperplasia without atypia, biopsy has to be repeated after 6 months. And then we have to look whether the lesion has resolved or not. So similarly, in a patient with an atypical hyperplasia, if fertility is not required, they have high risk, it is always better to go with the surgery. Plus or minus BSO based upon their age group and the other requirements. But if surgery is not indicated, there's any contraindication and they require fertility, that is when we do an endometrial biopsy for them. And that is when we give endometrial biopsy and we give the progesterone supplements for them. And atypical hyperplasias has to be followed up in 3 months. So if you see a patient whom you think that they may not be willing for follow-up after 3 months, or they may not be able to understand the depth of the disease, or if you feel that it is very difficult for them to follow up, it is always advisable for them to undergo hysterectomy, especially in a higher risk of age group, in patients with endometrial hyperplasia or atypia. So the follow-up endometrial biopsy is done. So if there is a regression, then we can continue the Mirena for 5 years, can continue the oral progesterone for 6 months, and if they still have a bleeding PV on top of the Mirena or the oral progesterone, it is always advisable to undergo surgery.
Let me add here that those with perimenopausal AUB, if you have hyperplasia, with atypia or without atypia, this conservative management you can do, but you have to give continuous progesterones. You should not give cyclical progesterones. But anybody postmenopausal with these, even with hyperplasia without atypia, it's better to do hysterectomy. So don't confuse the both. When I said we don't put Mirena for postmenopausal. Postmenopausal bleeding with any abnormality, definitely you have to do hysterectomy. With any abnormality like hyperplasia with or without atypia, we have to do hysterectomy. But perimenopausal, you can give them that period for follow-up if you think your patients are going to come for follow-up regularly, but you have to give continuous progesterones.
Okay, ma'am. Thank you, ma'am. So in perimenopausal and postmenopausal patients with endometrial hyperplasia, we have to give continuous progesterones, ma'am, or
postmenopausal, we have to do surgery. They have hyperplasia with atypia, without atypia.
Surgery.
But in perimenopausal, I'm saying, if they have hyperplasia without atypia, you can give progesterone, but give progesterone continuously for 84 days like that. Usually, we'll give medroxyprogesterone 10 to 30 mg. You can use continuously for, daily for 84 days like that. But even in perimenopausal age group with atypia, it's better to go for surgery. All this thing of following up for every 3 months or 6 months, it's not very practical actually. Patients won't come for endometrial biopsy that often, and each endometrial biopsy has its own cost. With ultrasound, we have to do ultrasound before that, then the endometrial biopsy. So everything is an expenditure for the patient, and follow-up also becomes difficult. So you have to consider all these practical problems before we decide what we want to offer to the patient. But we can, of course, explain to them these are the possibilities. Even Mirena we can put in for perimenopausal. Some people even try depot medroxyprogesterone. All these are different modalities of treatment. Only for hyperplasia without atypia. With atypia, I think better to operate. Yeah.
Yes, ma'am. I think only patients perimenopausal women with just plain hyperplasia, we may better to offer the progesterone treatment. Perimenopausal with atypia, postmenopausal with any kind of hyperplasia, better to opt for surgery. So yes, ma'am. That's more. Thank you, ma'am. And so next is ovarian tumors is the next most common tumors in this age group of our index case that we discussed today. So we have different types of ovarian tumors in which there are surface epithelium tumors, stromal six-core tumors, and germ cell tumors, in which epithelial tumors are more common in the older age groups, more than 50, 60 years of age, whereas germ cell tumors are more common between 10 to 12 years of age group, and six-core stromal tumors are more common in the 30 years of age group. So ovarian tumors are also common risk factors include old age, nulliparity, infertility, early menarche, and late menopause. Endometriosis is an important risk factor for ovarian tumors, endometrioid carcinoma, and genetic syndromes like BRCA and Lynch syndrome, and white race. So, who needs to be screened for an ovarian malignancy? It is not recommended in general population. So, patients who have a positive genetic test in view of familial cancer syndromes, they may need a CA-125 plus transvaginal ultrasound 6 monthly from 30 years of age. So these are the methods of screening for epithelial ovarian cancer. The most ultrasound is ideally cannot be able to pick up in stage 1 ovarian cancer because of it's not a cross-sectional imaging, but for screening methods in high risk, we can do that. So this is just an orientation about, there is something called as ORAC scoring, which is used in used as a criteria to categorize a patient with an ovarian tumor on imaging, that they fall under low risk, intermediate risk, almost benign, or high risk. So any patients who fall from ORAC 3, they need to be referred to a gynecologist for MRI or further management. So, what are all the USG characteristics suggestive of a ovarian epithelial malignancy in ovarian masses? So, size more than 10 centimeters, the solid or a solid plus cystic complex cyst, multiloculated cyst with a septal thickness of more than 2 millimeters, and cyst wall thickness of more than 3 millimeters, which is bilaterally present with increase in vascularity and papillary excrescences. So, CA125 has actually high false positivity rate. So, serial increase in CA125 is more suggestive of malignancy than a single value. So, but if we have a cutoff, the normal cutoff is more than 35 in case of postmenopausal women and more than 200 in case of premenopausal women. It has a low positive predictive value, actually. That's why using the multimodal screening, RMA is commonly used in screening for ovarian malignancies. So, in case of women who are high risk for ovarian cancer, it is always better to start them on OC pills, which can actually prevent ovulation and reduce the risk of ovarian cancer, but it's not fully protective. So, prophylactic bilateral salpingo-oophorectomy is offered to those patients who are of high risk of ovarian malignancies at 35 to 40 years of age, along with hysterectomy if they also are family history of HNPCC or they have genetic markers for HNPCC. Tubal ligation can help only in case of endometrioid carcinomas. I think this is the last slide. So I think we've discussed as much as possible about a brief outline on managing AUB in primary care. So any patient who comes with you an abnormal uterine bleeding, it is always important to do a pelvic exam, even while they are bleeding. Why? Because of we may never know what we are having. They may also be having any pregnancy-related complications or ectopic pregnancy. So it is always important to do a vaginal exam, even while they are bleeding. Patients may feel not very comfortable, but it is always advisable to do examination even while they are bleeding to for a proper diagnosis, and that is the ideal treatment. That is the basic thing to be done in a patient with an AUB. So there are some sayings that while bleeding they may not be willing, so you don't have to do PV, or they may be uncomfortable, or there may be pain, or it will be difficult for physicians to handle it. That should not be the reason to not do PV examination. So I think I've done about the ma'am. Sir, anything you want to add? And any doubts are welcome. Any questions you have, any doubts you have, any common scenarios that you face, they are welcome. You can ask in the chat box. You can ask later in the group also once you think about it.